Hi, this is Brian Kim. I'm going to share with you case number 34 in the best way to do cataract surgery series. This is a soft lens and a toric lens. The IOL manufacturers have always suggested rotating the lens clockwise into position, but that means if the lens needed to be rotated literally maybe a few degrees counterclockwise, they would want you to rotate the lens around 170 degrees or 160 degrees clockwise. And in my mind, that really makes no sense. I don't think you have to do it that way. And in fact, the key is to make sure that the eye is completely inflated. And this is because as the eye is inflated, the haptics are not touching the capsular bag, and you'll be able to very gently rotate the lens clockwise or counterclockwise without any difficulty. However, if you don't feel comfortable inflating the eye and doing a two-handed technique, then yes, you should rotate the lens clockwise. You don't want to traumatize the capsular bag or the zonules. So I'm using my corneal mark to help me center and size my rhexis. I'm using a cotton tip to turn the eye towards the left. This allows me to have a more flat approach when I make my paracentesis inferiorly here, and then superiorly I'm using the Q-tip again to turn the eye so I can have a flat approach parallel to the iris plane for a self-sealing corneal incision. I'm injecting some intracameral lidocaine, and then I'm going to inject some intracameral dispersive viscoelastic. I use a cannula to hold the eye steady so I can do my triplanar corneal incision. I make a vertical groove, place the blade into the groove, tunnel through the cornea, turn the eye, and then dimple down, and then enter, and that's the triplanar corneal incision. I open up the incision with the forceps, with the teeth closed. I puncture centrally and then pull downward towards me, and this is the puncture style rhexis. I grasp the capsule and then go around circumferentially, trying to follow the corneal mark, which will help me to center and size my rhexis. I'm grabbing and then re-grabbing every few clock hours, and by doing so, I'm able to reduce viscoelastic egress, follow the corneal mark, which will again help me center and size the rhexis. I turn the corner here, finish off the rhexis, and then I'm going to burp some viscoelastic out of the eye. And then I'm going to begin the capsular fornix hydrodissection technique. I'm going to go in and then go out to the contralateral equator underneath the anterior capsular rhexis edge, turn the tip down. You get a nice fluid wave decompressed to the left side. I'm freeing up the anterior capsule surface on the left side, and then turn the tip down on the right side, and you can see the lens spins quite nicely. Start with irrigation first, turn irrigation off. I'm going to lift the incision, go in with the Phaco-tip with irrigation off to minimize Descemet's trauma. I'm going to remove the surface epinuclear material, which will create an epinuclear ridge. I'm going to place a chopper out underneath the epinuclear ridge out to the capsular equator. Turn the Phaco-tip vertically, subincisionally, bring both instruments together, crush the lens. This is a double chop. Place the chopper out to the contralateral equator, crushing the right heminucleus, pulling the chopper towards the Phaco-tip, and that is a cross-chop maneuver. I bring the chopper out around that first quadrant, crushing it against the Phaco-tip, and then emulsifying it. And then I pull the second quadrant up with the chopper, and then crushing the lens material with the chopper against the Phaco-tip. I've turned the second heminucleus in front of me, place the chopper at the equator, pulling it centrally and crushing the lens material against the Phaco-tip, placing the chopper into the equator again around the third quadrant, crushing it against the Phaco-tip, and then emulsifying the lens piece. This is a fairly soft lens. You can see the CDE is 0, and this is primarily using high vacuum and crushing forces to disassemble the lens. I get the chopper out around this fourth quadrant, crushing it against the Phaco-tip, and then very carefully with high vacuum emulsifying the lens piece. Again, I'm crushing the lens material between the chopper and the Phaco-tip, using the chopper to crush it against the Phaco-tip, using high vacuum to emulsify and remove the lens piece. When there's a small remaining amount of lens material, you want to keep that chopper deep to the Phaco-tip so that it protects the posterior capsule. Once all the endonucleus is removed, remove the chopper, push BSS with the cannula, take the phaco tip out, and switch it with the INA handpiece. I start sub-incisionally, get right up to the anterior cortical material, so it peels off from anterior to posterior. You saw I was able to remove the cortical material fairly easily here. It's a fairly clean bag. I'm polishing underneath the anterior capsulorhexis edge, but then I quickly switch to the polish mode. I can be much more aggressive polishing underneath the anterior capsulorhexis edge. You can see there's some fine cortical material that I'm able to grab. I can do this much more confidently because the aspiration vacuum levels are so much lower. After I'm done with the anterior portion, I polish the posterior capsular surface, removing any potential lens epithelial cells, and then I'm pushing BSS through my paracentesis into subincisional fornix. You can see there's some cortical material that was liberated doing this. It's kind of like a pressure wash technique. I'm pushing some cohesive viscoelastic, and then using a capsule sweep, I'm first polishing the capsule on the left side, and then I will do it on the right side. I try to be as efficient as possible and try not to have any wasted movements or wasted instruments when I do the cataract surgeries. With the sweep still in the incision, I inject a single piece acrylic toric intraocular lens into the capsular bag. The leading haptic goes into the bag. Because it's a toric lens, I'm going to use the sweep to separate the haptic individually, the leading and trailing haptic, and then reposit the optic completely into the bag. This patient's toric axis is about a 15-degree target, which is supposed to be about 15 degrees counterclockwise to my horizontal mark, as you can see here. And so this patient's actually more like at 170, and I need to move it counterclockwise to about 15 degrees. And so what I'm going to do simply is go underneath the lens, tilt it, and I'm approaching it from the left side. I'm tilting it. By tilting it, I'm able to turn the lens counterclockwise within the bag. I don't know if you noticed that movement. It was just a very quick and easy movement. And now the lens is actually in the 15-degree orientation. I'm polishing underneath the anterior capsule surface. I'm using the axis marker to again check where I am, and I'm exactly at 15 degrees, which is perfect and what I wanted. I'm polishing underneath the anterior capsule rim again. I'm just tapping the lens, making sure that all the viscoelastics were removed out of the bag. I'm double checking with the axis ring to make sure that I'm still on axis. And I'm push BSS with irrigation on, come out, and then try to minimize flattening of the chamber and then quickly hydrate my incisions. So you can see I was able to turn the lens very easily by keeping the bag inflated. In this case, I just tilted the lens with the INA handpiece and tilting and going underneath it and rotating it counterclockwise. Alternatively, you can use a second instrument, turn the lens counterclockwise within the bag. Again, as long as the bag is completely inflated, it's very safe to turn the lens counterclockwise with this technique. So I hope this was helpful to you, and I thank you for your attention.